hailing from Tirupattur with an education qualification of third standard, who was previously a coolie doing farm works by occupation and was off work for the past 4 years, and she's a homemaker now. She presented with chief complaints of breathlessness on exertion for past 4 years, and palpitation on exertion for past 4 years, and chest pain on exertion for 6 months.
Okay.
History of presenting illness. History of presenting illness. Patient was apparently normal before 4 years. History of breathlessness on exertion was present for past 4 years. Insidious in onset. She was gradually progressive. She initially noticed difficulty in breathing during her routine farm works, like pulling out weeds, assisting her husband in plowing, which were well tolerated. For the past 1 year, she had worsening of symptoms in the form of difficulty in walking around her house or even to nearby shop, and also in difficulty in lifting pot, which was NIHA class 3. History of paroxysmal nocturnal dyspnea, which was in the past 6 months. About 5 to 6 episodes of paroxysmal nocturnal dyspnea was present in the past 6 months. History of orthopnea before 3 months, for which she was admitted in Rajiv Gandhi Government Hospital. A diagnosis of heart disease was made, and she was treated with IV drugs, probably diuretics, and discharged after 1 week with daily oral medications, probably penicillin.
Right.
History of palpitation on exertion for past 4 years. She initially noticed forceful thirting sensation against chest wall while doing her routine farm works, such as pulling out weeds and assisting her husband in plowing, which were previously well tolerated. NIHA class 2, which was relieved by rest, and for the past 1 year, she had worsening of symptoms while walking around her house or lifting pot, which was NIHA class 3 and relieved by rest. This was insidious in onset, fast and regular, and not associated with giddiness or syncope. History of palpitation at rest for past 6 months. It was sudden onset and offset, and it was fast and irregular. It's not associated with any giddiness or syncope. History of chest pain exertion for the past 6 months. Retrosternal compressing type of pain, just non-radiating, incidence in onset, gradually progressive. Chest pain was present while doing her routine household activities, which belong to CCS class 2, which is relieved by rest, and history of syncope was present 1 episode before 5 months while doing household work, with regaining of consciousness within a few seconds. It is not associated with palpitation, confusion, involuntary micturition, or defecation. No history of cough with expectoration, no history of hemoptysis, no history of prolonged fever with joint pain or skin lesions in the remote past, no history of hoarseness of voice or difficulty in swallowing, no history of abdominal distension, reduced urine output, or facial puffiness, no history of recurrent lower respiratory tract infection or bluish discoloration of skin and mucous membranes or squatting episodes in the childhood. Coming to past history, she was diagnosed to have a heart disease during her antenatal screening during her last conception, which was 16 years ago, and she was advised regular oral medications, probably penicillin. Patient discontinued drugs after delivery, and the delivery was also uneventful. She was not a known case of diabetes, hypertension, bronchial asthma, pulmonary tuberculosis, CKD, cerebrovascular accident, or seizure disorder. No history of any surgeries in the past. Coming to personal history, patient consumes mixed diet, normal bowel and bladder habits, no known addiction were present. Coming to the menstrual, marital, and obstetric history, she attained menarche at 13 years of age and having regular cycles. She was married at 14 years of age, and para 3, live 3, all were normal vaginal deliveries and were uneventful. Last childbirth was before 16 years. Family, she was born out of non-consanguineous marriage and no history of any cardiac disease or sudden cardiac death in the family. Summary: a 36 years female with no known comorbid illness, with a previous diagnosis of heart disease during the AN screening echo of her last conception, and which was uneventful and lost to follow up, presented with breathlessness and for 4 years, which worsened from NIHA class 2 to 3 over the past 1 year, and with chest pain and exertion, and 5 to 6 episodes of paroxysmal nocturnal dyspnea and 1 episode of syncope within the past 6 months, with history of hospitalization for orthopnea before 3 months.
So fine. So
Right.
can you hear me?
Yes, sir.
Am I audible? Okay.
Yes, sir.
So you have the cardinal symptoms are shortness of breath, palpitations, chest pain, and syncope, right? So what do you think is the cause of shortness of breath in this patient? Or what are all the causes of shortness of breath that you will consider with this kind of history?
So the patient is an engaged female with a previous diagnosis of heart disease, and she had a slow progressive dyspnea. I would like to attribute this to um, valvular heart disease, probably LV inflow obstruction, and she could also have
What is dyspnea? What is dyspnea? Can you define dyspnea?
an unpleasant awareness of one's own breathing. So,
What is this orthopnea?
difficulty in
The
breathing
patient
on
had
lying down.
orthopnea and PND. Yeah.
Yes, sir.
What is orthopnea?
Orthopnea is difficulty in breathing on lying down position, which manifests immediately after lying. And paroxysmal nocturnal dyspnea is a type of breathing difficulty which manifests 2 to 3 hours after going to sleep, and it will be relieved within 30 minutes on waking up, sir.
So why is it coming 2 hours after sleep? Why doesn't come immediately like orthopnea?
So it can be attributed to shift of the fluid from extravascular to intravascular compartment and overloading of heart, and the upward movement of the diaphragm, and sympathetic activity during REM sleep. So all may precipitate uh, dyspnea, sir.
So all these phenomena are active in our you and me as well, right? So why don't we get PND?
So this patient with a suspected valvular lesion, the heart could not accommodate the increase in preload.
It is very important that in the background of underlying heart disease, an LV
Yes,
inflow obstruction or an LV systolic dysfunction is something that is very important. Now, is this dyspnea always due to left heart disease or it can be due to right heart disease?
it can be due to right heart disease also, sir. It may be due to renal perfusion, hypoperfusion, leading to increase in RAS and increased water and fluid retention, which may manifest as dyspnea, sir.
What are the mechanisms of dyspnea associated with right heart disease or right heart failure?
Stimulation of RAS and increasing the salt and water retention, causing increase in intravascular volume, leading to increased preload to the heart and increased workload.
See, the cardiac output is reduced, right? With the right heart failure, the cardiac output is reduced. The exercising muscles, they have a lesser cardiac output. So this can stimulate the metabolic receptors in the muscle. This can produce dyspnea. Or the reduced cardiac output in the lungs can reduce oxygenation in the lungs, like forward output to the lungs. You can even have a burn heme effect, right? So
Yes,
sometimes
sir.
increased right ventricular pressure can put a burn heme and reduces the LV output. That can also work on this area. Other thing is you can have opening up of patent foramen ovale due to elevated right heart pressure, and this can lead to right to left shunt and desaturation. And because of the desaturation, again, the chemoreceptors can be stimulated, and this can lead to edema. Even the weight increases due to fluid retention, and coupled with the reduced blood flow to the respiratory muscles, carrying out the bigger weight can also lead to dyspnea. So dyspnea can be due to multiple reasons. Not just because of left heart disease, but also due to right heart disease. How
Okay.
often do you get PND per night?
Right.
Usually, commonly one, sir, 1 episode, sir.
Why is that? Why don't you get 2 episodes? Sir, he is the only student available, or any other students we have called? Only one student?
I think he's the only one, or he is going to present the history and somebody else will present the examination part.
Okay, right. So you already gave the answer, Shafiq, that it takes some time for the fluid redistribution to take place, so that the intravascular volume has to increase. It takes about 2 to 3 hours. Then he wakes up and gets up, and it takes about half an hour, 45 minutes for him to settle down. Then he go back to bed. So imagine he goes to bed by 10 o'clock, he gets a PND by 1, 2 o'clock, and then it is very difficult to, he'll get up by the time. So it takes a longer time. That is why generally we get only one episode of PND per night. Which
Okay, sir.
NOHA class, is this? What do you think about NOHA classification? Do you agree with that, or you disagree with that? Or what are the difficulties or the fallacies of NOHA classification?
So the fallacies or NOHA classification did not comment about any response to therapy, sir. If the patient is on IV diuretics, so the response to therapy is not mentioned, and it varies from observer to observer, sir. And it does not comment about any exacerbating factors like anemia, infections. Uh, yes.
More importantly, the inter-observer variation is very high.
Yes.
How many PNDs can occur in a night?
One PND, sir.
David? Have you
One
heard?
PND.
Huh?
One PND, sir.
How? Why?
So due to redistribution of the fluid into the intravascular compartment and increase in intravascular volume, which under the background of valvular heart disease, the heart could not accommodate the excess in preload, sir.
So no, that only one PND occurs at night because for settling the PND it takes again 2 to 3 hours.
Yes, sir.
Yes, that completes the whole night, right?
Yes, sir.
Now tell me, if the orthopedic patient can have PND?
No, sir.
Why?
Because there will be breathlessness immediately after the patient goes to supine position, sir. So he will be having a difficulty in sleeping supine for a long time, sir.
So redistribution doesn't occur. Right? As you have said.
Yes, sir.
And diaphragm is low down.
Sir? Sorry, sir.
Diaphragm is also not putting up, no? So orthopnea.
Yes,
So
sir.
PND is very unlikely. It doesn't occur, yes.
Yes.
And syncope is due to
reduced cardiac output, sir.
Define syncope. I think Dr. Kajal is asking you about syncope, right?
yeah.
What are the cardiac causes of syncope, Dr. Shafiq?
Sir, arrhythmias,
Okay.
fixed LVOT obstruction like valvular aortic stenosis, subvalvular aortic stenosis, dynamic LVOT obstruction like hypertrophic obstructive cardiomyopathy,
Okay.
atrial fibrillation causing embolization to brain, LV clots dislodged into systemic circulation causing stroke, which may present as a transient ischemic attack.
What is the commonest cause of syncope in the community?
Vasovagal syndrome. Vasovagal syndrome.
Urocardiogenic vasovagal syncope is a common. What is syncope? Define syncope.
So it's a transient global hyperperfusion of the cerebral territory with a loss of with a spontaneous regaining of consciousness.
With that's not right. You're not talked about loss of postural tone, right? Did you talk about it?
No, sir. Loss of postural tone and consciousness followed by regaining of consciousness.
Why does it regain immediately?
Due to auto-regulation, the uh, perfusion to brain has resumed immediately in 2 to 3 seconds, sir.
Hmm.
Cerebral
When
auto-regulation.
assume when they fall down, what happens? The hydrostatic pressure changes, right? They come down, the cerebral perfusion increases automatically.
Yes.
So that's why we often, when somebody is giddy, we make them lie down.
Lie flat, sir.
So the patient had chest pain. Was it an angina or not angina?
Anginal pain, sir. She suffered from
The
pain
three
while doing,
cardinal things for a typical angina.
sir, a retrosternal compressing type of pain with aggravated with exertion and relieved with rest, sir, or nitrate, sir.
So this patient had all the three.
Why
Yes,
the
sir.
symptoms?
Sir.
One by one, patient has all the symptoms.
Yes,
Okay.
sir.
So
Chest pain, non-exertion.
sorry, please, Tiwari ji, go ahead.
He has all the symptoms. So,
Yes.
can you summarize which valvular heart disease is
Yes.
all because of?
Sir, the patient has a gradually progressive breathlessness
Oh,
and palpitation on
that
exertion.
that we understand. So,
Okay.
on the basis of history, you said possibility of valvular heart disease.
Yes, sir.
So, which valve?
Sir, LV inflow obstruction with the LV outflow obstruction.
Which valve?
Mitral valve stenosis, sir. Mitral valve stenosis with
Mitral valve involvement. Yes.
aortic
Most
stenosis with regurgitation, sir.
okay. So in mitral valve involvement, is it because of mitral stenosis
Yeah.
or mitral regurgitation?
Predominantly due to mitral stenosis, sir.
Okay. So why it is so that in a if there are two patients, one has isolated severe mitral stenosis and the other patient is severe aortic stenosis, where the symptoms increases as the severity of the mitral valve increases. But in aortic stenosis, most of the severe aortic stenosis patients are asymptomatic. Why is it so? You understand?
No, sir.
See, you have two patients. One is mitral stenosis.
Okay, sir.
So if you see the natural history of mitral stenosis, as the severity of the stenosis increases, you understand,
Yes, sir.
become more severe.
Yes, sir.
The patient also becomes symptomatic.
Yes, sir.
Initially class 2, then become class 3. Unlike aortic stenosis, where in severe AS, patients are asymptomatic.
So why is that? There is asymptomatic status is so often seen in severe aortic stenosis, whereas it is less often seen in mitral stenosis.
Yeah, that's right.
Yes.
Do you have any other colleague, your colleague?
Yes, sir.
Is he there?
He is there to present the investigation part, sir.
But he can also answer the questions.
He can also join. I think, if you're
Yes,
there,
yes. Both of you. So that everybody, even we also pick up new things. So,
Right.
what's your name?
Dr. Ravani.
Can you answer few of the questions?
if you want to take another system and join, you can take another system and join also from another room. Choice is yours.
Okay.
So come back to the question what Professor Tiwari asked you.
So your patient, okay, let's move forward. Your patient is 36-year-old. So
Yes,
first possibility you keep as valvular heart disease, preferably left-sided valve involvement, mitral stenosis. Is that right?
Yes, sir.
Okay. along with aortic valve involvement or isolated mitral valve involvement on history basis?
Along with aortic valve involvement, sir.
Okay. So in mitral stenosis, is there any history of why angina occurs in a severe mitral stenosis?
In mitral stenosis, there may be atrial fibrillation and there may be coronary embolization, sir, which may precipitate as an angina.
Very good.
How often you get atrial fibrillation in mitral stenosis? What is the incidence of atrial fibrillation in mitral stenosis? You understand my question?
Yes, sir. Yes. Increase of the age, sir.
Depends on?
Depends on age, sir. As the patient's age progresses and with the associated mitral stenosis, a patient crossing 50 years of age may have, because of even age-related factor also associated, patient may develop atrial fibrillation.
Now, this patient, your patient, are you suspecting they have atrial fibrillation or they don't have atrial fibrillation?
Yes, suspecting, sir, because the patient complained of wrist palpitation, which was fast, and sudden onset and offset, which was irregular, sir.
What Professor Justin is asking, that a patient of mitral stenosis can have a angina. Your patient, we are discussing your patient.
Yes,
Okay.
sir.
So,
Yes, sir.
okay, other way around. What is the cause of chest pain in your patient?
So in my patient, the patient had chest pain on exertion, sir, which was exertional,
What
which
is
I
the
can
cause?
aortic stenosis, sir.
Aortic stenosis.
Yes, sir.
Okay. Okay. What is the cause of angina? What is the how it happens in aortic stenosis?
During exertion, the heart uh, with the exertion and the patient having a fixed LVOT obstruction, the heart could not increase the output for the exertion, sir. The demand mismatch, sir. It's a precipitate angina.
What is nocturnal angina? How it is different from the conventional angina?
The nocturnal angina is seen in aortic regurgitation patients, sir. When sleeping, the heart rate goes down and there will be more regurgitation, which will precipitate pain, which will reduce the coronary perfusion, leading to angina, sir.
So, Dr. Shafiq, how it is different from the atherosclerotic coronary artery disease angina?
It is precipitated by exertion, sir. The not
No, both can precipitate.
aortic.
See,
Okay.
the difference is that it prolongs much longer duration. Number one. Secondly, it don't respond to the usual,
Yes.
nitroglycerin.
Nitrates don't respond. Yes, yes, they don't respond to nitrates. Can pH produce angina?
Sir?
pH, pulmonary arterial hypertension.
Yes, sir.
Oh.
So in
What are
mitral
the mechanisms
stenosis,
of angina in pulmonary hypertension?
Sir, in pulmonary hypertension, there will be reduced perfusion of the left side of the heart, reduced LV output, resulting in coronary hyperperfusion, causing angina, sir. Or pulmonary, if the pulmonary artery dilatation, it can compress the coronary arteries directly.
Which
So it can
coronary
also.
artery? Which coronary artery it will compress? Which coronary artery can get compressed by a dilated main pulmonary artery?
Left coronary arteries.
Left main coronary artery
Left main, sir.
can get compressed. Okay, so this patient, was she given oral anticoagulants? Did you ask that history?
Yes, sir. She did not take any oral, which was, I asked by whether she was taking any medicines in the evening, and she refused for that, sir.
Why do you think, you said you suspect atrial fibrillation. So, what is the incidence of thromboembolism and atrial fibrillation due to mitral stenosis? Are you able to hear
Yes, sir.
me?
Yes, sir.
What is the incidence of thromboembolism in atrial fibrillation due to mitral stenosis? Or when do you get thromboembolism? Early in the course of the disease or late in the course of the disease?
Late in the course of the disease, sir.
After atrial fibrillation, it takes a long time for it to develop emboli, is it?
Yes, sir.
No, you are wrong. Emboli happen very early. In fact, 1/3 of all the emboli happen within 1 month of atrial fibrillation onset, and 2/3 happen within 1 year of atrial fibrillation onset. So it's very important you start anticoagulation therapy as soon as you diagnose atrial fibrillation. What decides the frequency of embolism in a patient with MSAF?
Size of the LA, sir.
Size of the LA? No.
And the rate, sir. Ventricular response, sir.
No, you're wrong. It does not depend on the severity of MS, does not depend on the cardiac output, does not depend on the size of LA. It depends on the size of the LA appendage.
Yes.
And age of the patient. The frequency of embolic episodes. So it's very important we anticoagulate the patient, and that's important.
Right.
So where are we now? So you talked about PN, dyspnea, chest pain, palpitation. Did you talk about palpitation? You didn't discuss palpitation. What is palpitation?
Unpleasant awareness of the one's own heartbeat with a change in amplitude, rate, and force of contractions.
So due to change in rate, rhythm, or force of
contraction.
So what do you think? What are the causes of palpitations?
Sir, sinus, if it is exertional, it may be sinus tachycardia, sir. And if it is breast palpitations, maybe arrhythmias, sir. Tachyarrhythmias.
Learn to always classify and answer. It can be resting palpitations or exertional palpitation. If you look at what is the etiological, when you discuss palpitations, you need to discuss about the frequency, what are the initiating factors, what are the relieving factors, how long does it last, what are the associated findings. So what do you think was this palpitation due to? Was it exertional palpitation or a resting palpitation or both?
Yeah.
He had both exertional and resting palpitations, sir.
So palpitation is it due to, what was the exertional palpitation due to? Is it a regurgitant lesion or a stenotic lesion?
Maybe regurgitant lesion, sir.
Why do you say that? Why do you say that? Simple question I'm asking.
Sir, increase. Staircase phenomenon, sir. There will be increase in force of contraction with increase in heart rate.
Anyway, find that out. So what do you think? What is your summary you come to? What are your possible differential diagnosis? Tiwari sir, shall we go to the next step?
Yes, please, sir. Please, sir.
Yeah, 30 minutes gone. So go to the diagnosis. Go to the differential diagnosis.
Yes, sir. So my first differential diagnosis is acquired valvular heart disease with LV inflow and outflow stenosis and outflow regurgitation, probably of rheumatic etiology. And second differential is hypertrophic obstructive cardiomyopathy.
Why do you think it's rheumatic etiology?
Because patient was.
Yeah, please.
The patient had a slow progression of symptoms with associated with diagnosis of heart disease during her AM screening echocardiography.
4 years only, no? 4 years. It's not a slow progression, right? Slow progression, 4 years.
The initial diagnosis was made 16 years ago, sir. While doing her AM screening, she was found to have a heart disease and was advised regular medication on a daily basis, sir. But
what medication she was on for last 16 years? Does she receive Panadol prophylaxis?
Yeah, penicillin prophylaxis probably, sir, but patient did not take, was lost to follow-up, sir. She did not take any medicine, sir.
Okay. So when you said rheumatic heart disease, chronic rheumatic heart disease, and
Yes, sir.
some valvular involvement, acquired valvular heart disease. So second possibility, that is hypertrophic obstructive cardiomyopathy, HOCM.
Yes, sir.
Okay.
You think it's
Can it be
consistent?
dilated cardiomyopathy?
Sir, in any age group, if the DCM will have a sudden worsening and decompensation, sir, worsening as a volume overload state or worsening dyspnea, sir.
Any other possibilities? Any other etiology? Congenital heart disease?
Apart from this, I could bring in a bicuspid aortic valve also, sir.
Okay, okay. What is the natural history of bicuspid aortic valve?
The patient will have a early worsening of symptoms. Probably stenotic lesions are more common, and followed by regurgitation or combined lesions. And the patient will have a earlier worsening than a rheumatic AS.
Okay.
So anyway, I think bicuspid aortic valve, you won't be able to explain your PND and orthopnea, right? When do you get PND and orthopnea in mitral stenosis? In aortic stenosis?
So in aortic stenosis, if there is a elevation of LV end diastolic pressure, or if the LV goes for decompensation, patient may have PNDs.
Generally towards the terminal part is what in get that.
Can it be restrictive cardiomyopathy?
Sir, no precipitating or any other comorbidities suggesting an infiltrative etiology, sir, and no systemic manifestations also, sir.
What will be the findings, presenting symptoms of restrictive cardiomyopathy?
Yeah.
You're not talking about that.
Will be dyspnea will be predominant, sir, and can have arrhythmias, but angina is exertional angina in case of infiltrative cardiomyopathy is less likely, sir.
So do you get right heart symptoms in restrictive cardiomyopathy?
Yes, sir.
Then you are not talking about that.
Yes. More involvement on the right side.
So
Okay,
you
sir.
have, pedal edema, that right-sided congestion symptoms will be predominating there in restrictive cardiomyopathy, which this patient doesn't have. Okay, you go to the examination.
Right.
So general physical examination. Patient is conscious, oriented, afebrile, moderately built, and poorly nourished. No pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. No skeletal abnormalities. Hyperpigmented patches were present over the malar region. Anthropometry,
What are those patches?
Sir, might probably pointing towards the mitral facies, sir.
What is mitral facies?
There is a purplish hue on either side of the malar eminence, sir, due to
Due to? Due to what? Who described mitral facies? Did you read Paul Wood's paper on BMJ on mitral heart disease? He discusses mitral facies very nicely. It is due to vasoconstriction and desaturation due to peripheral cyanosis coming in this area. Low cardiac output, peripheral cyanosis, vasoconstriction all happening in that area. That is what he described as mitral facies there in that paper in BMJ. Go ahead.
height 154 centimeter, weight 36 kg, and BMI is 15. Arm span is 157 centimeter, and upper segment lower segment ratio is 0.9. Coming to the pulse, the pulse is 80 per minute, irregular, low volume pulse with no specific character. Pulse deficit is 14 per minute. All peripheral pulses were well felt and symmetrical. No radio-radial or radiofemoral delay, no epicocarotid delay. Condition of the vessel wall is normal. Thrill is felt over both carotid arteries. Blood pressure, right upper limb BP is
How
90 by
you
70.
how you see the pulse deficit?
Sir, I will auscultate and feel the pulse at the same time, and I will count only for the missing pulses, sir.
Okay. So what it signifies? Pulse deficit of 14 per minute. Why it happens?
If it is more than 10, it suggests atrial fibrillation, sir. The pulse is not connected to the periphery, sir.
Okay. And
So
three,
you have
you
said,
said, sorry.
yes, only low volume pulse. In irregular pulse, you have said atrial fibrillation. It should be mostly low volume because pulse volume varies. No?
Yes, sir. Predominantly low volume, sir.
Yes, you must say that one. Right.
Coming to the blood pressure, the right upper limb BP was 90 per 70 and left upper limb BP was 90 per 70 and right lower limb systolic BP was 98 millimeter of mercury and respiratory rate is 14 per minute, which was regular, and thoracoabdominal type. Saturation is 98% in room air and temperature is patient is afebrile. JVP is elevated with the top of oscillating column seen 6 centimeter above sternal angle at 45-degree head up position. A wave is absent and other waveforms are seen, sir. Fundus examination is normal.
So now at this point of time, how are you going to narrow down your diagnosis? So far, you've done your general examination, and their basic examinations. What are the information that we're able to get? Hemodynamic informations.
The patient is in atrial fibrillation, sir.
Very good. The patient has atrial fibrillation. Then,
And the pulse pressure is narrow, signifying and the pulse volume is low, signifying outflow tract obstructive inflow or outflow tract stenotic lesion, sir. Left side of stenotic lesion.
that doesn't say that. No. You can have a low pulse volume due to multiple reasons. You can't use that to say that, this has whatever. Somebody
Elevation of the right heart
Galaxy
pressure.
A32 has switched on the video. You can switch off the video. Who's that? Galaxy A32. Yeah, fine. Somebody was, yeah, fine, good. Please keep your video off. If you need to keep the video on, make the environment proper and keep the video on. Right, go ahead.
And there is a RV pressure overload, sir.
Why do you say RV pressure overload?
As the JVP is elevated.
No, JVP elevated doesn't mean RV pressure overload. It's a right heart failure. It's all.
Right heart failure.
It doesn't mean RV pressure overload. The patient has a right heart failure. The patient has an atrial fibrillation. Now, any other information? You said outflow obstruction. Do you get any? What are things you look for in outflow obstruction? You said the patient had syncope. The patient had aortic stenosis. Suspected aortic stenosis, angina. So obviously, you should be having severe aortic stenosis. So, what you don't find anything over there, or you have some thing to help you out there?
There's a drill over both carotid arteries, sir.
Okay, good. So there is a thrill over carotid artery. Then, what else you would have find? There is no epicocarotid delay. What does that tell you? Why there is no epicocarotid delay? What are you trying to tell us by that?
It will be there will be epicocarotid delay in case of hemodynamically significant severe aortic stenosis, sir.
So you are talking about a patient where the cardiac output is low, and you said AS is contributing to it. The patient has angina, and the patient has syncope, and the patient has thrill over bilateral carotids. And now you say the patient does not have a hemodynamic significant aortic stenosis. That doesn't gel well, right?
Okay.
So, did you really look for epicocarotid delay and it was not there, or you didn't do it in the right way? How did you look for epicocarotid delay?
I palpated both the apex and carotid simultaneously, and I looked for correlation between the LV thrust and carotid upstroke, sir.
Anyway, you always need to re-verify if some finding is not matching your, ultimate conclusion. So you have, this is the information that you have so far, right? Move forward.
And the JVP is raised. A wave is absent.
Yes, sir.
Okay.
Right. Carry on.
So cardiovascular system examination, inspection and palpation. Trachea is in midline. Chest wall bilaterally symmetrical. Apical impulse felt in left sixth intercostal space, 2 centimeter lateral to the left midclavicular line. It was heaving in nature. Palpable P2 was present in left second intercostal space. Sustained parasternal lift present. Diastolic thrill felt in left third intercostal space along left sternal border and apex. Bilateral carotid thrill was present. Bilateral supraclavicular pulsation seen. Epigastric pulsation is present, probably aortic pulsation, and no scars and dilated veins.
So you have a lot of findings in your cardiovascular examinations. So how are you going to, coordinate with this or come to a hemodynamic diagnosis with these findings?
So the down and the apical impulse is shifted down and out with the heaving in nature. Probably LVOT, aortic stenosis with enlarged LV.
You can't say aortic stenosis. You can't say aortic stenosis. You can only say
pressure
LV
overloads.
systolic
LV
pressure overload. Fine.
That is LV pressure overload with the down and out shifting of apical impulse indicating enlarged LV and associated diastolic thrill in left third intercostal space. I would like to give a diagnosis of LV stenotic and volume overload, sir. Pressure and volume overload, sir.
So stenosis, what is the evidence for stenosis here? LV outflow stenosis, what is the evidence here?
Bilateral carotid thrill was present, sir.
Okay, thrill was there doesn't mean that there is outflow stenosis. So whatever information you can get, you can get. You said you can say LV systolic overload accepted. Dilated,
diastolic overload.
Yes, diastolic overload. You can say that probably we can accept it.
With pulmonary hypertension.
Pulmonary, very good. Pulmonary hypertension, you can say that. Or RV systolic overload is something that will be a better word. Why do you say pulmonary hypertension?
The patient had a palpable P2 in left second intercostal space.
What are the causes of RV systolic overload that you can examine? What are the causes of RV systolic overload?
Causes, sir?
Yeah.
Pulmonary artery hypertension or left-sided stenotic lesion.
Not left-sided, right-sided, man. RV systolic overload. So, two common things are RV, pulmonary hypertension or RV outflow tract obstruction. Because the P2 is palpable, you can rule out a significant RV outflow tract obstruction at the valvular level. So that is why you suspect, you can say the patient has a pulmonary hypertension.
Yes.
As the patient has pulmonary. So you have good information. So why do you say it is aortic pulsation in the epigastrium?
If the pulp of the finger is placed over the epigastric region and the pulse is felt in the pulp, then it is aortic. And if it is in the tip, it may be due to the RV pulsation, sir.
Why are you telling probably? Because you have evidence of RV pressure overload. So probably you will expect RV pulsation. Why do you say aortic pulsation?
I felt the pulsation to be in my pulp of the finger rather than in the tip, sir. So I felt it was aortic pulsations.
Was the patient, what is the BMI of the patient?
15, sir.
15 only, thin patient.
Yes.
Okay, right. It is possible. Then otherwise, with a BP of 90/70 with the pulse pressure of 20, you don't really expect aortic pulsations over there, if not for the very low BMI. Right. Go ahead.
Percussion, right heart border is substernal and left heart border corresponds to the apex. Left second intercostal space is dull. Liver dullness noted in a right fifth intercostal space along with clavicular lines.
So now you need to know what to look for. Now go back. So as of now, you have diagnosed atrial fibrillation number 1. You have diagnosed LV pressure overload, number two. You have diagnosed LV dilatation, number three, and probably LV diastolic overload, number four. And we have diagnosed an LV inflow obstruction, probably mitral stenosis, number five. You have diagnosed a pulmonary hypertension, number six. So all these diagnoses you have already made by before putting a stethoscope on the patient.
Yes,
Now,
sir.
with this background, you need to go back and look for. You need to know what to look for in each of these places. You can present now.
Coming to the auscultation, S1 is variable, predominantly loud. S2, P2 is loud, with a normal split, no added sounds. Coming to the murmurs, a high pitched, harsh, crescendo decrescendo, ejection systolic murmur of grade 3 by 6, peaking in late systole, heard all over the precardium with the maximum intensity in right second intercostal space along right sternal border, with the diaphragm of the stethoscope in sitting and leaning forward position, with breath held in expiration, and the murmur radiated to both carotid arteries.
What added sounds were you looking for? You said no added sounds.
So in presence of mitral stenosis, I would look for opening snaps, sir,
Okay. So you had
or
a
RV S3 in RV failure and RV S4 in case of pulmonary hypertension, sir.
so you didn't you look for them. You didn't get them.
Yes,
Good.
sir, I didn't get.
So S1 is predominantly loud. Probably if the MS is there, that sort of tells you that you should expect an opening snap, but we really don't have it. That's fine. So you have one murmur, it is here, it's a systolic crescendo decrescendo, late peaking murmur. So what are you expecting with the late peaking murmur and the second heart sound? What do you expect with the late peaking murmur and the second heart sound?
Valvular aortic stenosis, sir.
Now, what will you be finding in the second heart sound if you expect get a late peaking murmur?
Paradoxical splitting, sir.
Yeah, a paradoxical splitting. You look for it. It was
Yes, sir.
normal split only.
It was normally split only, sir.
Mhm. Right, fine. Because whenever it is speaking late in the history, it means that aortic stenosis is severe and it is likely to push the A2 behind P2. Right, fine. Go ahead.
And is there is a carotid upstroke delay as well?
Yes, sir. No, sir. I could not feel that, but only thrill I felt, sir.
No, is there any carotid upstroke delay?
No, sir.
Yes or no?
No, sir.
Okay, go ahead.
Second murmur, a high-pitched, soft-blowing decrescendo, long-drawn early diastolic murmur of grade 4 by 4 is best heard in left third intercostal space along left sternal border with the diaphragm of stethoscope in sitting and leaning forward position with breath held in expiration. Intensity of the murmur increased with the hand grips.
And this murmur is
This murmur is due to aortic regurgitation, sir.
so you have not told about how much it occupies the diastole.
Long drawn early diastolic murmur, sir. More than 2.5 diastole.
Yes, when you say long drawn, you probably you are implying that it is beyond more than 50% of the diastole. But it's always good to verbalize it. It makes it more clear that you are trying to tell that it is a severe aortic regurgitation. So that is the only important thing that examiners will be looking for instead of calling long drawn. Long drawn is not a term that we usually use for early diastolic murmur. Long drawn is now we use for mid diastolic out of mitral stenosis. Here, you saw decrescendo occupying more than half of the diastole. That is what something that we look for. Go ahead.
Okay, sir. A high-pitched, blowing pan-systolic murmur of grade 3 by 6, shared burst in air pulse in left lateral position with the diaphragm of the stethoscope with the breath held in expiration. Murmur was radiating to left axilla and back, sir. A
This is
fourth murmur,
because of
mitral regurgitation, sir.
So it radiates to left axilla and back.
Yes, sir.
Okay.
And second murmur, you are giving a grade 4 by 4. What do you mean by that? You have a diastolic thrill there?
Yes, sir.
The diastolic thrill is because of aortic regurgitation.
Yes, sir. The turbulence of the blood flow crossing
So you have
during
a
the.
diastolic thrill, but not because of MS, but because of AR. Or you have
Yes, sir.
diastolic
The
thrills.
thrill, the thrill was localized to second aortic area, sir. So I preferred to correlate it with AR, sir.
Did you say that in your examination? Go back to
Yeah,
your chest
the palpation, I have mentioned diastolic thrill, sir.
left third space. Okay, right. Next, come back. So, but you didn't get a mid-diastolic thrill.
No, sir.
That is
It's
surprising. Why is that? You get a diastolic thrill of MS more likely than a diastolic thrill of AR.
Yeah, a very good question. Very good.
sorry, sir.
Why do we often get a diastolic thrill of mitral stenosis and we don't get a diastolic thrill of aortic regurgitation? See, I would have seen very few cases of aortic regurgitation with thrill, not more than 5 cases probably in my entire career. But we see diastolic thrill of MS so often. So, but you have
Mhm.
seen in the early part of your career one case of diastolic thrill of AR. So, my question to you is, why is that AR diastolic thrill is less common than MS diastolic thrill?
Due to increased gradient across the LA and LV, causing more turbulence, resulting in thrills.
No, no. So you have to talk about physics characters here. It is not about the gradient here. It is the sound has an amplitude and a frequency, right?
Frequency. Yes, sir.
So what about the amplitude? Which character is important in transmission? Amplitude or frequency? A,
Frequency.
a frequency, a low frequency, a low pitch sound moves,
And
travels faster. There is less interference. Just like, why do you have a danger signal red is because red has a lower frequency. It travels longer and can be seen at a distance. And similarly, any low frequency sound or a low frequency murmur is transmitted well across the chest wall. And that is the reason the low pitch or the low frequency murmur of mitral stenosis is well felt in the chest wall, whereas the high frequency, high pitch, and pitch is nothing but the conscious recognition of frequency. The high pitched murmur of aortic regurgitation is generally not felt, not very loud like the rumbling diastolic murmur of mitral stenosis. And that is also the same reason sometimes we feel the LVS3. We can feel the LVS3, we can sometimes see the LVS3, but the loudness may not be that great. But very rarely you get, early diastolic thrill of AR. So in the exams, you have to be extremely careful before committing that it is a diastolic thrill of AR. Very often it is seen in cases of severe AR related to infective endocarditis where the jet may be hitting directly at the apex. There also you often get the thrill in the apex. AR thrill can be felt in the apex, particularly when the jet hits the apex. Anyway, go ahead.
sorry, low pitched, rough rumbling, long drawn mid diastolic murmur of grade 4 by 4, best heard in the apex, in left
So you
lateral
have one
position
more
with.
diastolic thrill.
Yes, sir.
There are two diastolic thrills.
Yes, sir.
Go back to your inspection, your chest wall. Did you talk about two diastolic thrills?
I didn't mention this.
You mentioned or you didn't mention?
I didn't mention.
You didn't
He
mention.
only mentioned one diastolic thrill in the left third intercostal space and
And
bilateral
apex. And apex is mentioned. And apex. We had not noticed that. Okay, right. Surprising. I would like to see the patient. Is the patient around?
Not right now, sir.
Right. Anyway, call the patient. Go back to the inspection. Go back to the auscultation. Yeah.
So you have four murmurs.
Yes, sir.
One of aortic stenosis, other is aortic regurgitation, Mitral regurgitation and MDM.
MDM, mitral stenosis, sir.
Okay. Any other auscultatory findings?
No, sir.
How do you differentiate MR murmur from AS murmur in the apex? That is what Dr. Tiwari wants to know.
Sir, associated findings of aortic disease and mitral valve disease, it has to be examined, sir. And the mitral registration murmur will radiate to the back and the apex, sir. Whereas the aortic stenosis murmur will be localized to the apex, sir.
What will happen with the hand grip?
The hand grip aortic stenosis murmur will reduce and mitral registration murmur will may increase, sir.
So, this is what I know, right?
Sir?
Next.
Next
So
slide.
what is there any other auscultatory finding?
No, sir.
So what are the other positive finding in your general on other systemic examination?
Sir, other systemic examination was normal, sir.
Okay. So what is your diagnosis?
Sir, acquired valvular heart disease, probably rheumatic etiology, severe aortic stenosis, severe mitral stenosis, with a moderate aortic regurgitation and mild mitral regurgitation, with severe pulmonary arterial hypertension, mild pulmonary venous hypertension with medications, and the patient is a NIHA class 2, and the atrial fibrillation with the controlled ventricular rate with medications, and no evidence of active rheumatic fever or infective endocarditis or congestive cardiac failures.
Why do you say severe aortic stenosis?
So the apical, the patient had a narrow pulse pressure with a low volume pulse and
Listen, they are not for severe aortic stenosis. Low pulse pressure, narrow, they are not for severe aortic stenosis. There can
the
be
patient had a late peaking ejection systolic murmur, sir.
Late peaking murmur in the absence of a precordial thrill and in the absence of a paradoxical split. What is more stronger? You at least had a heaving apex.
Heaving apex.
Why do you say moderate aortic regurgitation? You have a diastolic thrill of aortic regurgitation. And
Yes,
you have a long drawn, in your words, aordiastolic murmur, long drawn aordiastolic murmur, and a diastolic thrill of AR, and you say it's a moderate AR. It's not acceptable.
Sir, the pulse pressure was narrow and there was no peripheral signs of AR.
So the patient is in heart failure, the patient has two severe outflow obstructions, two obstructions, one outflow and one inflow. Then how can you expect a peripheral signs in AR? Patients in failure. In fact, three obstructions: severe pulmonary hypertension, severe mitral stenosis, and severe aortic stenosis. Three obstructions along the circulation.
Can you have a severe aortic regurgitation in spite of absence of peripheral signs?
Yes, sir.
In what conditions?
What is that?
Dysfunction.
Acute AR?
Yes, sir. Acute AR will not be getting peripheral signs, sir. A failing ventricle. We cannot expect a peripheral signs.
Okay. And why you said severe MS?
Sir, the patient had a long drawn mid-diastolic murmur with pulmonary hypertension. So,
why do you say mild PDH? In patients of PLD?
So at present, the patient had no orthopnea PND, sir.
Yes, but still, you say it is mild PVH?
The patient might have improved with diuretics, and the symptoms have the congestion might have gone down, sir. So current clinical function status is NIHA class 2, and the pulmonary venous hypertension was mild, sir.
Right.
Mild means how much?
Sir, mild.
Much.
So how will you classify PVH?
Yes.
Sir, it is grade 1, 2, 3. So grade 1 is 12 to 18, and grade 2 is 18 to 25, and grade 3 is more than 25, sir.
Okay. So you feel because of the diuretic therapy that the patient presently doesn't have orthopnea right now?
Yes, sir.
When you examine, no orthopnea, no PND.
No PND, sir.
So obviously, if the patient doesn't have an orthopnea at the time of your examination, you can't say severe. No PND at the time of your examination, not severe. If she is ambulant, say NOHA class 2 with medications and you saw her, fine. We can accept that it is mild PVH at this point of time because it's, of course, pulmonary venous hypertension can be labile with medications. Right. It's 4 o'clock now, 4, 5, 4, 8. So you can move to, shall we
Yes.
move to the investigations, Dr. Kajal?
Yes.
Yeah, please. Go ahead.
Yes.
Please. Go to the slideshow.
This is the ECG of the patient. Normal standardized ECG. Here we can see the heart rate is around 126 per minute, and interval is very irregular and prominent. No, we are not able to see any distinct and regular P waves suggestive of atrial fibrillation. And with heart rate of 126, it is atrial fibrillation with a rapid ventricular rate. And coming to QRS, the QRS axis was in the extreme right axis. With QRS, it was a narrow QRS with duration less than 120 milliseconds. And you can see
extreme right axis. What is the QRS axis?
We can see very prominent R movement in the AVR.
Yeah, there are many leads which are biphasic. I think lead 1, 2, and 3 are sort of biphasic with AVR positive and AVL positive. AVL positive also. So it is a little difficult to say, extreme right axis, but it is okay.
Minus 90 degree.
Right, minus 90 to minus 120, agreed. Fine, no issues. Right.
And you can see the deep S waves in V2, V3, V4, V5, and with positive T waves. So we put in Karno's criteria of S wave amplitude and R wave amplitude in V3 and AVL. It comes as positive for left ventricular hypertrophy. As well as with this underlying prominent R waves, there is a positive T waves. So possibility of both LV pressure as well as volume overload is there.
Why LV pressure overload?
So the S wave in V3 plus R wave amplitude in AVL is more than 20 mm. So Karnal's criteria fits into
LVH. We agree, but why do you say pressure overload?
No, sir, it's LVH and LV volume overload. So there is no down sloping ST segment with negative T waves in lateral leads. One AVL.
Q waves are still seen. The Q waves are still seen in
yes, persistent Q waves more in favor of volume overloads.
Is there evidence of left atrial enlargement?
Since no prominent A waves, if it is we see more of coarse A waves with a large amplitude, coarse fibrillatory waves, they may favor left atrial enlargement.
Any other way of identifying LA enlargement? QRS V1 by V2 by V1 ratio. You're aware of that? Is there RA enlargement in this patient?
Small Q with R wave, prominent R wave in V1. be suggesting a right atrial enlargement, sir.
A Q in V1 could indicate RA enlargement.
RA enlargement, sir.
Total QRS amplitude 3 times that in V2, 3 times that of in V1 could indicate LA enlargement. Anyway, the patient has AF here with LV volume overload, right? Go to the X-ray.
So this X-ray taken in PA and lateral view, we can see that the cardiothoracic ratio is more than 0.6, and we can see the straightening of left heart border with prominent pulmonary areas and prominent left atrial appendage area, and the apex is more of RV type of apex. I see it is upturned, and we can also see there is a shadow within shadow, and stable atrial contour is seen, suggestive of left atrial enlargement. And,
What are the structures formed on the left heart border?
Just keep your cursor and trace them and answer Professor Tiwari one by one. Left heart border, keep your cursor there on the left heart border and explain what do you see.
So here this is aortic aortic arch coming down. You can see here coming down as this descending aorta. So this part is formed by aortic arch. Then next comes your
Call the aortic knuckle.
aortic knuckle.
Yes.
And
Yeah, what
will
is
be
that
the
part?
one second.
Cursor is fine. Cursor is fine. It is very well seen. Don't worry.
Okay, sir.
And,
Yeah, we can see it.
This will be the pulmonary bay, followed by left atrial.
pulmonary bay. What is pulmonary bay?
Not a bay here. It appears very prominent.
Yeah, don't say that pulmonary bay. Bay is something, it's just concave. You understand that, like the Bay of Bengal, it is a concave inwards. So the pulmonary, it's a fullness there. Pulmonary artery fullness is seen there.
Pulmonary artery fullness, sir, followed by
And then,
left atrial appendage.
very good, left atrial appendage then.
Appendage. And then?
Say LV or RV? You are not audible.
Since the apex is more of RV type of apex, upturned apex, I suspect to be usually it is formed by left ventricle, but it could be due to right ventricle, sir.
It's an inspiratory film or expiratory film? Go back.
This is inspiratory film, sir.
It develops
more than
inspiration. 1, 2, 3, 4, 5, 6th, 7th rib, almost it is there. Like, anterior 7th rib, it has come down. And if you look at the posterior 1, 2, 3, 4, 5, 6, 7, 9, 10, 11, almost it is beyond the 12th rib.
It is down and out.
Yeah, and that is why, you are getting the appearance as if it is upturned. Because it is, in fact, deep inspiration. It's LV apex only. And what are the ways left atrium can enlarge? Yes, you can
atrial
X-ray.
left
can enlarge. What are the directions LA can enlarge?
It can enlarge towards right. It can enlarge above. It can enlarge
Towards the right. How do you see in the X-ray?
Towards the right, we can see the shadow within shadow can be seen. If it enlarges above, it will hinge upon the tracheal bifurcation. It can lift left bronchi, leading to this slaying of tracheal carina.
Very good.
And it can enlarge towards the left, leading to straightening of, contributing to the straightening of left heart border. And it can also enlarge posteriorly, where it can compress upon the esophagus.
Not compress, it can push the aorta out, right? It can compress the esophagus. As you can see in the lateral view, you can see the LA is quite seen posteriorly in the lateral view. So LA has gone posteriorly also. LA cannot enlarge inferiorly. LA cannot enlarge anteriorly. See, these are the directions left atrium cannot enlarge.
Yes, sir.
So do you see your SVC? You said a jugular venous pressure is elevated and 6 centimeters. Are you seeing the SVC? Where do you find the superior vena cava?
SVC should be here, sir.
You don't see that.
That is not there.
Not prominent, sir.
So probably the X-ray was taken at a different time than your examination, maybe.
Yes. So
Yes,
how
sir.
will
With
you
the
explain
medication.
this? How is there any cardiomegaly?
The cardiothoracic ratio is increased, sir. It could also be due to the left atrial enlargement.
Oh, left atrial enlargement will cause cardiomegaly. Your apex beat is where in see what you say is sixth down and out.
Yes, sir. There is increased cardiothoracic. Yes, sir.
How will you explain that?
Yes, sir. Left ventricular enlargement can also cause this increased cardiothoracic ratio here. Because as we can see from the lateral film, the retrosternal shadow is still persistent, no RV enlargement. And so the CT ratio can be explained only with the left ventricle or the left atrium, sir.
No. How will you explain the? You said severe AS. There is a moderate AR, mild MR, and severe MS.
Yes, sir. The
So why it is down and out?
The atrial regurgitation could be one reason for this LV enlargement, and ECG also was showing signs of left ventricular volume overload.
But you said aortic regurgitation is moderate, and the murmur occupies only the 50% of the diastole.
Another possibility is severe aortic stenosis gradually progressing to left ventricular failure. And
so this patient has got mitral stenosis, severe.
yes,
Will it modify the findings of aortic stenosis or AR? Which one will be modified?
Aortic stenosis will underestimate the symptoms and signs of mitral stenosis, and the mitral stenosis again will underestimate the symptoms and signs of aortic stenosis because of the reduced LV filling in mitral stenosis, and because in the presence of aortic stenosis, the pressure gradient across LA and LV will be reduced. So both aortic stenosis and mitral stenosis will underestimate each other.
Right.
The X-ray, is it a left lateral X-ray or right lateral? No, there is written as left lateral, but don't worry about that. If it is not written, how are you going to identify? What is left lateral? What is right lateral? How do they take a left lateral X-ray?
The film is placed on the left chest, and the projection is from the right side. Then it is left lateral X-ray, and if it is
very good. That is the film is placed on the left. It is a left lateral X-ray. So how do you differentiate a left lateral X-ray and a right lateral X-ray?
we see that usually the cardiac, the heart rests on the left hemidiaphragm more, and if we can trace the cardiac border over the two diaphragmatic borders, here we can see that heart is resting over the left heart border, and this is.
So whichever side is the X-ray, that side diaphragm will be lower. Here you can see that the left diaphragm is lower than the right diaphragm. Left diaphragm is identified by the gastric bubble. Right.
Okay.
Right.
Move forward. Go to the echo.
So this is parasternal long axis view showing a dilated left atrium, and there is thickening of anterior and posterior mitral leaflets with doming and hockey stick appearance of anterior mitral leaflet. And we can see that the mitral valve separation index is 5 mm. And we can also see the LV outflow tract and thickened aortic leaflets. And so this is the short axis view taken at aortic valve level, again showing thickened aortic valves.
What else
And,
it was showing? Go back. What else it was showing?
there is
Play that the short axis view. Something interesting is showing, you're not talking about it.
What is the cavity?
There is LA appendage.
there is left atrial appendage. We can see a thrombus.
Oh, you're not
Yes.
talking about that. Why are you missing it? You are presenting it and we are seeing it. You are missing what you are presenting.
And
Was,
echo contrast delay.
was it mentioned the echo report or not?
Not mentioned.
What man? Seeing such a big thrombus there. Patients are anticoagulation, right?
Yes, sir. Valvular AF is an anticoagulation.
So after echo, ECG and X-ray, what is your final diagnosis?
This is a rheumatic heart disease with severe mitral stenosis, mild mitral regurgitation, moderate aortic stenosis, and moderate aortic regurgitation. Normal biventricular function, mild pulmonary arterial hypertension. Patient is in atrial fibrillation, and no IE, and there is left atrial appendage clot.
While it is down and out, there is a cardiomegaly. How will you explain the cardiomegaly? Number one. Number two, you said P2 is loud, but here you are mentioning mild PAH, pulmonary arterial hypertension. How will you explain this?
Based on the echo is echocardiogram is showing reduced tricuspid TR peak gradient was only around 36 millimeter of mercury, and pulmonary artery.
Can you have mild pulmonary arterial hypertension in severe mitral stenosis?
It has to be severe, sir, with this LA enlargement and the patient's clinical findings.
And you said
dilated.
And you said P2 is loud.
Yes, sir.
So it is not going what you are telling. Okay.
Likely a severe pulmonary hypertension.
Professor Justin Paul, can you like to have some comments, sir?
On mild pulmonary hypertension in the presence of severe mitral stenosis, sometimes of course, when we plan a balloon mitral valvotomy for a severe mitral stenosis, we end up seeing the TR pressure gradient of 35, 36. Even today, we had one patient where we had the TR pressure gradient was 36, suggesting a PA pressure of around, say, 40, 42, but the MVO was 0.8. This could be related to good dehydration of the lungs by diuretic therapy, where the PVH comes down significantly. When the PVH comes down, the passive component and the reactive component of the pulmonary arterial hypertension can come down. Probably that is one way you can, to some extent, explain lower pulmonary arterial hypertension in the presence of a severe mitral stenosis.
But he was mentioning P2 is loud.
Yeah.
So how can you say mild PH?
Sir, I mean, I personally feel that in the clinic bedside, you cannot, my personal opinion, you cannot classify them as mild, moderate, and severe. Because the findings that are used to classify them are very vague. It varies depending on the various examiners. There is no objective strong criteria. So, I don't really harp on this particular point on the bedside. Significant pulmonary hypertension or no pulmonary hypertension, I'm happy with that. If the student says
Dr. Shafiq,
that.
uh, When you will say that P2 is loud clinically?
If the P2 is here in the apex also, then we can call it as loud, sir.
Sorry,
When you,
say
sorry,
that.
If
I'm Dr.
the
Bang. I'm asking you, how do you say P2 is loud?
sir, it can be compared with if the P2 sound is also shared in the apex,
If
then it
if
can,
it's louder than A2, then you say P2 is loud, not because it is heard in the apex.
The louder than A2, we have some reservations here because A2 is soft. So when you have a two, what shall I say, two sounds and you try to compare with one another, it becomes variable. So the more objective criteria is that P2 generally not heard in the apex. So the classical teaching is when you hear a P2 in the apex, it is considered as loud.
Right.
Yeah, but the when it comes to loudness, it is usually compared with A2. That's
Right.
what Paul Wood said. Paul Wood said that when you say P2 is loud, it has to be compared with A2. If it is louder than A2, then definitely P2 is loud.
I'm not sure what Paul would say, sir, but then when we apply the logic, we can find that in a patient like this with severe aortic stenosis,
Yeah,
the soft A2.
I don't know. This was
Yeah,
the
so
standard teaching that how do you compare A2? When do you say P2 is loud? When it is louder than A2. That this is what,
yeah,
and it is palpable.
yeah, P2 palpable, fine. P2 palpable again, thin chest wall, we can have a P2
I
palpable.
think chest
So
wall, but
we generally prefer
if it
the
is,
student to say that one
sometimes
point is
you
that,
can
sir.
feel a diastolic shock clearly.
Yeah, perfect. Yeah, great. One hard point is that P2 is never heard in apex. If it is heard in the apex, it is loud. So if the
Yeah,
student,
but
generally we are happy about that.
yeah,
Right.
but
Yes.
sorry.
Dr. Shafiq, what is your plan now?
stabilization, the patient has been stabilized with the medications, and in the presence of severe mitral stenosis and an associated moderate
Sorry,
significant
not, there is some audio problem, not able to hear what you are saying. Say again, repeat again.
sir, with hemodynamically significant mitral stenosis and moderate aortic lesions, stenotic and regurgitated lesions. I would ideally the patient can be treated with a double wall replacement, sir.
Hmm.
Okay.
Now, if
Dr. Tiwari?
yes,
So
yes,
what is
Dr. Ganguly, yes, Professor Ganguly, you are saying something, sir.
It's all right. Can we move to time is not permitting us. Dr. Justin, will you say something about prosthetic valve?
Yeah, do we have time? I think 4:30 is already over, but if you want, I can just say put out a few words.
Few words.
Okay. I did make. We have some slides here. So I think Shafiq and Navanitharan, you did a good job. I think
Yes,
you
good job. Thank you.
stop sharing. We couldn't go to the management part of it. Or should I think you got to stop sharing, Naveen, so that I can share the slides that we have here. And I hope you are able to see the slides.
what are you presenting for
So
prosthetic?
he asked me to present on prosthetic valves. Dr. Kajal messaged me that the types of prosthetic valve and the choice of prosthetic valve. Am I right, Professor Kajal? Is that what you want? Yeah,
Yes.
I'll try to finish it. He gave me 20 minutes. I'll try to finish up in 10 minutes because we are already late. So, as we are all aware, we have tissue valves and mechanical valves. In the mechanical valves, we have the disc valves and the cage valves. Star Edwards is a cage valve. Somehow we hardly see them. But let me tell you, I've never seen a Star Edwards valve thrombosis, but I see a lot of Bailey Fluid valve thrombosis. Somehow these valves went out of the market. But then, we are presently not marketing Star Edwards, but leaflets valves are there. Now, coming to the tissue valves, we can have, either a transcatheter bioprosthetic valve or a surgical bioprosthetic xenografts or homografts or autografts. When coming to the transcatheter, we have the balloon expandable valves and the self-expandable valves, which we all know very well. And the surgical, we have a stented valves and the stentless valves as well. So we can have a porcine, or Medtronic, or freestyle, or a mosaic bioprosthetic valves. In the autographs, we all know homographs, the pulmonary, we do. Now, when do you go for a mechanical prosthesis? There's one class one recommendation is that, it is recommended in patients who are at the risk of accelerated structural valve degeneration, like a young patient or somebody who has a hyperparathyroidism or a hemodialysis. They have accelerated structural valve degeneration. So, you can't have a tissue valves. Or in a patient in whom there is no long-term contraindication to anticoagulation. So these patients, mechanical valves can be considered. And also for a patient who's already on anticoagulation because of a mechanical valve in another position, we still can consider, if the patient already has a mitral mechanical valve, and we are going to put an aortic valve, we can put a mechanical valve. And then, coming to the other indications, if coming to the age part of it, anybody less than 60 years of age for aortic and less than 65 years of age for mitral is the age preferred choice for a mechanical prosthesis. Why 65 for mitral and 60 for aortic, 5 years more for mitral? The reason is the mitral valve operates at a higher gradient. LV systolic pressure minus LA pressure, which is much higher than LV diastolic pressure minus aortic diastolic pressure at which the aortic valve operates. So the stress and the shear is more in the mitral valve. So the related degeneration is likely to be more. So, you give another 5 years cutoff extra for the mitral valve. And any patient who has a reasonable life expectancy and in whom a repeat TAVI will be a high risk. Supposing somebody is expected to live for about 30 years and, TAVI is going to be a high risk, such patients we can have a mechanical valves. Who are you going to give bioprosthetic valves? Again, whenever a good quality anticoagulation is unlikely, and if there is a very high bleeding risk where we are not able to give oral anticoagulations with vitamin K, or the life expectancy is estimated to be 10 plus years, bioprosthetic valves are recommended. And whenever a mechanical valve thrombosis, we are doing a reoperation, we can have a bioprosthesis valve. So these are some of the indications how we can choose a bioprosthetic valve. This is a tabular column again from ACC/AHA guidelines. As you can see, age less than 50, we prefer mechanical prosthesis because at this age, there's an increased incidence of structural valve degeneration. And they have a lower risk of complications with vitamin K antagonist anticoagulation. When it is more than 65, where there is a lower incidence of valve degeneration and a higher risk of anticoagulation complications, we prefer a bioprosthesis. Patient preference is quite important. We do give importance to that. And the risk of long-term anticoagulation is also considered important, as we already saw in the first point. Now, we have a patient who is non-compliant, who is in a remote place, who can't regulate the VKA activity. In such patient, bioprosthesis may be considered. And patients where there is a transcatheter valve in valve is possible, the patient is financially affordable, such patients, even the younger age bioprosthetic valves may be considered. So as you can see that, this small tabular column with the prosthetic valve is required, and if the patient has a contraindication to anticoagulation, we can go for a bioprosthetic valve. If there is no contraindication to anticoagulation, and if it is a mitral valve replacement when repair is not possible, more than 65 a bioprosthetic valve and less than 65 a mechanical. In case of an aortic valve replacement, less than 50 a bioprosthetic valve is preferred in appropriate anatomy, in particularly when it is a pulmonic autograft. When it is more than 65 years bioprosthetic, less than 50 years mechanical, in between 50 and 65, I have a choice of mechanical and a bioprosthetic because you can always do a bioprosthetic, and in 15 years, if it degenerates, you can do a TAV, probably at 65, and then maybe a TAV in valve, and then a TAV and valve. It becomes like that. So now once you have done a bioprosthetic valve, the second part of it is extremely important. We train and educate the patients very well. We tell them, particularly when you're putting a mechanical heart valves, that if they stop anticoagulation, they're putting them into risk of death. There is something important considering the fact that we see so many prosthetic valve thrombosis day in and day out. In our prosthetic valve thrombosis registry, we have 400 plus case of prosthetic valves. We are just collecting data. We need to sit and write it up and publish. Clinical assessment should be performed yearly as soon as possible and whenever new symptoms occur. So a good clinical examination every year. And I personally prefer the transthoracic examination every year, once in a year. After transcatheter as well as surgical implantation of bioprosthetic echo and gradient should be measured within 30 days of the valve implantation at 1 year and then annually. The same thing for a mechanical valve also. So if transthoracic echo is not giving good information, you always need to suspect when there is, we need to train the patients, particularly mechanical valves, to listen to the valve clicks, the sharpness of the sound, the loudness of the sound. We should train them to go to a quiet room every day morning and see the loudness. If there is a change in the loudness, they need to come early for a follow-up. So NOVAX should not be given for mechanical prostheses. They have no role at all. Lifelong treatment, the VK is extremely important. And the rest of it all, you're all familiar with that. The postoperative risk of thromboembolism peaks at about 1 month after implantation. But then up to 6 months it is high, so we have to be extremely careful in managing the anticoagulation therapy. Target INR is something that is extremely important. We have prostheses of, we can classify them as a low, medium, and high thrombogenicity. A low thrombogenicity, we have Carbomedics, Medtronic Hall, ATS. These are the commonly used valves now. The Lilly Caster, Omniscience, and Starrett, Bioc-Shiley, we don't use them. So Bioc-Shiley and all, it used to be there, but then nowadays we don't use them. Bioc-Shiley, many Bioc-Shiley were recalled, and Starrett, we don't use them. They were all high thrombogenic valves. So predominantly, if you look at what we are using is only low thrombogenic valves. Then we look at the patient-related risk factors. What are the risk factors? We have 5. Mitral or tricuspid is a high risk. Previous thromboembolism is a high risk one. Presence of atrial fibrillation is a high risk. Any degree of mitral stenosis is a high risk, and LVEF less than 35. If the patient has more than or equal to 1 risk factor, we step up the target INR by 0.5. We have to ensure that if you are having the time in therapeutic range, the TTR should be more than 70. Normally, when we are doing an INR, when we expect a TTR INR of 3, we should be getting 3.1. When it is 2.5, we say that it is not in the therapeutic range. If we are doing 10 times, it has to be at least 7 times in the therapeutic range, and we call the TTR more than 70%. Whenever the TTR is not more than 70%, the thromboembolic events risk can be high. So this is again another chart of antithrombotic therapy. When you put a mechanical valve, you have to give a vitamin K antagonist lifelong. If the patient has a CAD in addition, please add a low dose aspirin in selected patient with low risk of bleeding. And bridging anticoagulation may not be required with the minor surgeries. If they are doing a bioprosthetic valve, well, this is the chart. This is very well available in the 2021. The students, I request you to kindly go through this chart in the book. And this again is an image I've taken from the Brownwald textbooks. I will not take much of your time here. Please go back and evaluation of aortic prosthetic valve stenosis. This is again from the Brownwald Czech textbook. So thank you very much. And I think I finished in within 10 minutes as I promised.
Yes.
Thank you.
Very good talk.
Very good. Thank you, Dr.
And I have one question to ask you, Justin.
Yeah, please.
Yeah, see, there's a notion trial. There are 3 notion trials, 1, 2, and 3. So from high risk, moderate risk, intermediate risk, and low risk.
Mm-hmm.
See, all 3, they compared the TAVR with the SAVR.
Yeah.
And the results of TAVR, especially if the orifice is small, seems to be better than the SAVR.
Yeah.
So these are some of the points which are totally, very different. And this low risk has put many things into perspective in a way which look contrary to what we have understood so far. And what is contrary? What is contrary is low risk. Contrary means low risk, age is low, and you are considering TAVR. Because especially if the orifice is small, because this gives a better long-term and better hemodynamic results. So this, I don't know how over a period of time, with improvement in the technology of this TAVR, the slowly, I don't know whether it will transform ultimately into everything will be TAVR or SAVR. That's my question.
I think you have a very valid point. I think the February last month issue of European Heart Journal, the 10-year long-term follow-up outcome of Notion study was published. So it is not 1 year, 2 year, 3 year, 5 year. It is 10-year follow-up, and you found that
10-year
those patients with SAVR versus TAVR,
that's what I read, and I just quoted you that.
Yeah, was very, very similar. So in the days to come, I think, we are going to have, I think we as cardiologists are going to have a bigger role to play. And I think the young students, aspirants who are there will be very happy about it, because by the time they are there, I think cardiac surgeons will start undergoing cardiology training as well. And I know they're already making perfect.
TAVR training, not cardiology training, TAVR training.
So now, they are integral part of the TAVR program.
TAVR program. And why I brought out this, especially for our PG students, because this will be a part of their curriculum. Now, they cannot avoid. They have to compare TAVR with SAVR and know all the data about it. Because question can be there in theory. And same way, if the case is there, long case or short case, question can be there even in practical.
I just want to add, Dr. Wang, that as you said, for small orifice, there is enough data and my personal experience also that for small orifice TAVR, self-expanding valve are better, has a better performance than balloon expander.
Yeah, even these days there are other types of valve which technology has combined. Modern technology has combined the Boston New valve, Accurate Neo, that they have combined the self-expandable and the balloon expandable technology into one, so that those low coronary setting, all those are taken care of. I mean, you can have 0 to 5 millimeter coronary setting, and yet you can do a TAVR without fear of getting blockage. That is one thing. Second, the size of the cells have increased tremendously. So, the size of the cell has become so big, they have become very big, almost 15 millimeter size of the cell. So you can easily plan a future coronary intervention. That's the main concern. Future coronary intervention, coronary blockages, while you do the TAVR. So Accurate Neo Boston, which has a both combined technology, they can be very good for small orifice, along with the low set coronary, small sinuses, along with the low set coronaries. So these are some of the points. These points might come up in the exam, especially when the latest ESC report of 10 years follow-up Notion trial comparing SAVR with TAVR. In fact, the hemodynamics are better in TAVR all the time.
So, thank you, Dr. Bang. Thank you, Dr. Justin Pal, Dr. Satyan Tiwari, and two presenters, Dr. Shafiq and Dr. Navanitharan, for a beautiful conversation. And I think we have at more than 250 attendees. All the PG students will be benefited. Thank you very much. And next time also, we shall have a number of sessions on this. Thank you.
Thank you very much. Thank you for us.
Thank you very much. Thank you, Dr. Ganguly.
Thank you, sir.
Thank you, sir.
Satyen, thank you, Dr. Justin Paul.
Thank you, Dr. Paul.
Thank you, Dr. Tiwari. It was nice.
Thank you.
Thanks,
my
sir.
friend Tiwari.
Professor Justin Paul. Yesterday, you was extremely busy late night for your cardio obstetrics session.
Thank you.
Very well organized.
Yeah. Thank you. Good. Thank you so much. Thank you so
And
much.
thank you, Professor Ganguly and Professor Bang. Nice to
Thank
hear.
you.
Yeah, nice. I think. Thank you.
Very nice.
Thank you, guys. I think thanks to my postgraduates for presenting the case. Thank
Yes,
you.
yeah. Thanks to who presented and who attended also.
Yeah.
Right.
Thank you.
Thank you, sir.
Bye.
Goodbye and stay safe.
Thank you, Professor Ganguly, sir.
Thank you, Satyen.
Thank you, sir.